Welcome to our Workplace Health Podcast. I'm Garlana Matthews, President and Editor of Workplace Health Magazine, your trusted source for comprehensive information on workplace health and wellness. Each month, I will be sharing interviews with leading industry experts to empower employers with the knowledge and resources needed to create and sustain a culture of wellness. Whether you're a business owner, HR manager, or employee, Workplace Health is your go-to resource for staying up to date with the latest trends and best practices in workplace wellness. If you're ready to address the diverse needs and challenges faced by businesses today, you're in the right place. Let's get started. Today, joining us is Dr. Gregory Kolovich. He is board-certified, fellowship-trained orthopedic surgeon specializing in hand, wrist, and elbow conditions. Through thousands of surgeries and years of experience, Dr. Kolovich has emerged as one of the region's most gifted hand specialists. His reputation is well-deserved. Though his path to success was not straightforward, Dr. Kolovich began his academic journey at Georgia Tech in Atlanta, studying engineering with aspirations of working for NASA. During his time as a student, a side job ultimately led him into orthopedics. While he was in school to earn extra money for rent, he started working for an organ and tissue procurement company. That's how he started getting interested in anatomy, dissection, and surgery. Although he completed his engineering degree, it served as a stepping stone to medical school at The Ohio State University. There, Dr. Kolovich studied under the renowned Dr. Michael Ruff. Dr. Ruff was a mentor for Dr. Kolovich. He really learned a lot from Dr. Ruff and liked the versatility of microsurgery. After completing a fellowship at Harvard University, Dr. Kolovich relocated to Georgia and joined Optum Orthopedics. His practice focuses on treating fractures, carpal tunnel syndrome, trigger finger, and trauma. While Dr. Kolovich utilizes the latest surgical techniques, he prioritizes non-surgical options first, such as physical therapy and regenerative medicine. Greg, thank you for joining us today on our podcast. We're so excited to have you. One of my questions is, what led you to specialize in hand surgery versus general orthopedics?
Of course. I think when we train in residency, we train in everything from pediatrics to spine, in some cases general, sports, foot and ankle. And for me, when I was a medical student, before I actually was an orthopedic surgeon, I was interested in orthopedics peripherally. And one of my mentors, Dr. Michael Ruff, he would let me come in on the weekends. So after working hard all week, I would sneak in the weekends and scrub in on cases, which was great for me as a med student. And this guy was an orthopedic hand surgeon, microvascular surgeon. He could do free flaps, he could do nerve, he could replace a hip, he could do everything. And one month we had this devastating farm injury. This was up in Ohio, in Columbus. Guy was hit with a big piece of farm equipment, tore his arm off. Dr. Ruff systematically put that guy's arm on and got him function. He did first of all, he debrided it, reattached the arm, did the, revascularization. He did the nerve repair, and then obviously played it, got fixation, got coverage, did a latissimus flap, free flap. I mean, this is a sequence of surgeries over the course of 3 months, but I sort of followed him along in this case. And I remember thinking, this guy's the X-Man. This guy's the doctor's doctor. I mean, surgeons come to this guy for help. He could do everything. And also then he could go and replace a knee and pin a hip and do all the other stuff that the general guys were doing. So I felt like he could scope a shoulder. I was like, if this guy can do everything, I want to be that guy, because I really did think that his training was incredibly inspiring. And then so I knew I wanted to be a hand surgeon because I felt like I could do everything. And then you'll ask a lot of people who train in hand. Our hand rotation tends to be the most confusing. It's challenging. We are labeled the nerds. We are the thinkers. We read a lot. I still read. I've never mastered the hand yet. I've been doing hand surgery for 12 years now. I still don't know it all. I'm learning constantly. There's so many enigmas and new things I learn about. The hand is continually evolving and advancing, and we come up with new problems, new overuse injuries based on how our society evolves. And I don't think we'll ever truly master the hand, which makes it extremely interesting to me because I don't think, just like you can't master life, you can never be perfect in anything. I always like that carrot out in front of me, like go get it, like go learn. And I really, I'm just, I guess I'm a nerd. I just like hand surgery. I like learning. It's a lifetime learning for me. So it was the perfect sort of marriage of my nerdiness, my competitiveness to do everything, and my interest in just helping others and being sort of a liaison for other doctors and surgeons.
I love that you've been, that you had a mentor, and now today you're probably mentoring other physicians.
Yeah. It's important. Well, it's important too. And then I know, we have med students that come in, and nurses don't always like it because they're slow, but they're learning. And I always tell my med students, I go, you have to learn. And it is a privilege to treat the next generation because one day they'll be operating on me, and I want to make sure they do a good job. So I think education, it can be lost sometimes in private practice where we're at. Fortunately, we do have Mercer Med School around. So I know several of us out to mentor a lot of med students. And I really do enjoy that. So I think it's really important to pay it forward and pass your knowledge and expertise on to the next generation.
Wow. So what makes the hand one of the most complex parts of the body to treat?
Well, there's a lot of quotes, and I'll butcher the quote, but a lot of philosophers say, if you don't believe in God, look no further than the complexity of the human hand. And I'm probably butchering that quote, but it's been passed along to me. And the hand is our window to the world. It's what allowed us to create this wonderful society. It separates us. Just the ability to have an opposable thumb, just to be able to bring that thumb out of plane. We are the only species with a truly opposable thumb. That has allowed us to build these wonderful things that we use today. This great society. It has put us above all other species, and it's the hand that allows us to do that. Now, developing brains, developing frontal cortex, all that processing that we've developed, but we needed a tool to use that processing, and that was the hand. So the human hand, to me, nothing gets more complex. If you ask anybody in training, they'll say their hand training is one of the most rewarding, but it's also probably the most challenging. And I really do like that. Even 12 years in practice, I still get challenged every day with new things. I have not seen it all. I constantly read and challenge myself to learn more about the hand. It's ever evolving, and our treatments are getting better. Our outcomes are getting better, and I truly believe that we are developing. As we develop new things in our society, we will develop new problems. So I don't think we'll ever truly solve the complexity of the hand. It's a mystery and it's a challenge.
Thank you for sharing that. One of the questions that I get a lot from the work comp adjusters, they would like for you to explain the difference between an orthopedic hand surgeon and a plastic hand surgeon.
It's a matter of training. In orthopedics, we focus more on bone fixation, hardware fixation. Plastics is more of the soft tissue, microvascular, nerve, tendon. But I think they marry well when you do a hand fellowship. So my hand fellowship at Mass General, we had 2 orthopedic trained and 1 plastic. It's always been that way. And I learned from the plastic surgeons as they learned from me. So when we did a hand replant or a finger replant, my plastics colleagues would walk me through microvascular techniques, just as I would walk them through scoping a wrist or a shoulder or plating a wrist. So I think there's a special skill set that you learn in residency that marries nicely when you do a hand fellowship. So I wouldn't say one's better than the other. They're just different thinkings. Plastic surgery is a heavy regard for soft tissue handling, microvascular, and orthopedics is more 3D spacing, arthroscopy, fracture fixation, a lot of the AO principles that we learn about fixing long bones and short bones, and achieving rigid fixation. Those are 2 different disciplines that have to marry well when you take care of a complex hand trauma. So I think it's a testament to our industry that we have plastic surgeons and hand surgeons, and I work closely with both of them.
Thank you for clarifying that, because we do get that question a good bit. What are the most common hand injuries you see in your practice? work-related hand injuries?
Well, there's always, repetitive traumatic carpal tunnel. A lot of people who work with vibratory machines, jackhammers, people who ride motorcycles, bikes, anything that repetitively vibrates the hand. Vibratory motion can be particularly damaging to nerves. It just always has been, and that can be work-related carpal tunnel or cubital tunnel. One thing that we often miss, is often underdiagnosis, is compression of the ulnar nerve in the hand. That's called Guyon's canal compression, and that's associated with vibratory issues at work. Of course, lacerations, traumas, crush injuries. Everybody crushes their finger at one point in their life. Just at work, they tend to be more traumatic. So crush injuries are very common. Falls, hand fractures, wrist fractures, tendon injuries with sharp penetrating injury. There's all sorts of things, and I think the thing I like about hand surgery is that it can be very black and white. I saw a kid today with a clear zone 2 tendon laceration, but it can also be very, very complex. You'll have someone with non-specific hand and wrist pain, and they may have normal imaging, normal EMGs, and sometimes that can be somatosensory too. It could be that can be a manifestation of internal anxiety. So there's everything from somatization to actually real black and white trauma at work, and everything in between, which makes it can be frustrating at times too to figure out what's real and what's not. But as I said before, your hand is the window to the world. So sometimes if you do have internal frustrations or anxieties, those can be manifested as pain, as real pain. And it's sometimes difficult for us to figure out what's objective and what's organic and what's not organic.
So one of my questions is, what are early warning signs people ignore that later become serious with the hand injuries?
The most obvious is carpal tunnel. People wake up and they shake their hand out and they say, my hand's numb, but I can splint it. The problem with carpal tunnel is it's progressive mononeuropathy. So you're compressing a nerve. Much like choking someone, you're starving them of oxygen. If your median nerves require a lot of attention, they require a lot of oxygen. If you're choking them by compressing them at the carpal tunnel, at the transverse carpal ligament, you can cause irreparable damage to the endoneurium and endoneural scarring, which can be irreparable. And sometimes we go and release the nerve, and it doesn't always come back because there's so much endoneural scarring. And that could be something that I wouldn't ignore. I rarely tell people with carpal tunnel to ignore it and splint it. Splinting is nice for mitigating symptoms, but ultimately you're not fixing the problem. And the bad part about carpal tunnel is people splint for years and it goes away. Well, carpal tunnel never goes away. It's a mechanical issue, right? There's not enough space in the carpal tunnel, so it'll never truly go away. And then they get that silent atrophy, and then they come back 10 years later, and they've got thenar atrophy that cannot be restored. So compressive mononeuropathies, ulnar neuropathy when you're getting clawing and weakness, atrophy in the hand. We've all seen somebody's hands that you can see all of the tendons and no muscle. Those are what's called intrinsic atrophy. That is irreparable if it gets to a certain point. And it is it's frustrating for me because they'll come in with clawing and weakness, and they'll have horrific atrophy and EMG that is showed extreme slowing, and I have to counsel the patients that I can't restore that, and that's because they let it go too long. Tendon injuries, flexor tendons in particular, should be treated within the first 2 weeks. I saw a kid today, and I'm going to sign him up for surgery on Monday.
So how was that injury? How did that occur? The injury to the flexor tendon?
Well, there's always a story. This one was a hedge trimmer. So you can imagine how traumatic that was for him. He got his hand caught in a hedge trimmer. But I have, if you can imagine it, I've probably seen it. Crush injuries, burns. I've seen people their hands crushed in presses, chewed off by sharks. Imagine it's happened. Hand surgeons see everything. And I've seen fireworks. I had one patient went on a date and was trying to impress her date by holding a firework, and it blew four of her fingers off.
Oh, now you're scaring me, because my son works on a tugboat, and they launched the fireworks for the 4th of July. So on the riverfront. So now you're really scaring me.
You have to be very careful. I'm sure he's got a stick where he lights them, where he lights the fuse. So just don't get your hand close to the firework. Don't be holding it.
Believe it or not, they're computerized. I think they're computerized now. The fireworks.
A firework is a bomb. It's probably one of the most devastating injuries that we'll see. It's not only a burn injury; it is an explosive injury. There's, it has no indiscriminately rips tissue, can crack right through bones. There'll be nothing left.
So. One of the questions, I'm sorry, I didn't mean to, because I wanted to ask you another question that leads to this. What is, in your experience, which industry has the highest risk of hand injuries?
Well, I mean, like if you're talking about, repetitive injuries, anything with vibratory or repetitive motion, those can be certainly can cause overuse injuries like tendinopathies, tendinitis, carpal tunnel. But then, I always say in hand surgery we have seasons. Like when I trained in Boston, we had seasons. We had snowblower season, we had fishing season. So in Savannah, in this town, in this area, fishing injuries are really common. Those tend to bring nasty infections. So a lot of the people who are boat captains, a lot of people who work on the ports. You can imagine these heavy crates swinging in the air with chains, pressure situation. There's going to be a lot of crush injuries, hand entrapment. Anywhere where you're working quickly and working with heavy machinery in a stressful environment that sometimes is can be hectic. Those are you can really imagine that. But I always sort of stratify hand surgery by seasons. We don't have 4 distinct seasons here in Savannah, but in Boston we definitely had 4. There was like the fireworks season around holidays. There was definitely a snowblower season. We had pumpkin knife injuries and avocados around Cinco de Mayo. We've got a lot of people who get pumpkin injuries. You can't imagine how I probably see 4 or 5 flexor tendon injuries with carving a pumpkin. That's not a work-related injury, but I mean, just imagine what you're doing with your hands at the time of day or what you're doing at work. And if you can imagine an injury, we've probably seen it. But yes, ultimately repetitive work in a stressful environment where you're doing a lot of repetitive motion in a hectic environment with heavy machinery is a recipe for a hand disaster.
Now, this is a difficult question. What delays or barriers do you see in the workers' comp system with doing workers' comp?
So this is a double-edged sword for me because I work in a multi-specialty group. So I've got partners that are spine surgeons that want to do workers' comp. I got people that don't. I've got partners that are general that want to kind of see everything and sort of pick and choose. Ultimately, it's good. I mean, if they're general orthopedic surgeons who want to take hand, that's fine. But ultimately, if it's a complex thing and it turns out to be you're delaying treatment. So I would argue that if you're going to do workers' comp and you're going to see hand patients, especially traumas like zone 2 flexor tendons, or nerve injury. It's always really frustrating when someone's seeing workers' comp patients, but they don't know how to sew a nerve or they can't do a TFCC reconstruction. It's like, well, maybe you shouldn't, because those are common injuries, right? Maybe you should leave those for the fellowship trained hand surgeons. I'm just saying that just like if I wouldn't see a back workers' comp, I wouldn't be able to operate on them. It's not my specialty. So I think if we stay in our lane, that can expedite things. But I think people try to, for whatever reason, see patients that maybe they're not specialized in, and that can delay care, because what happens is we'll spend a couple weeks doing conservative care, and maybe they didn't have the wherewithal to pass that along to their colleague, and then you got a flexor tendon that was missed. Happens all the time. You can't. I know how you miss a flexor tendon, and then they see you at 6 to 8 weeks. The most common one is actually an SL injury. There's a ligament in the wrist. It's called the scapholinguinate ligament. It's commonly torn. You feel a pop in your wrist. The patient will tell you. They said they were gripping something at work. They felt a huge pop. Of course, the X-rays are negative. They spend 6 weeks in therapy. They never get better. They get an MRI at 3 months and they show an SL tear. Well, you've now missed the acute window to fix it. So now you got to do a salvage procedure. So a ligament that could have been fixed easily was missed. just because it was seen by someone who doesn't really specialize or knew what to look for.
So if we would have got the injury into you immediately, you could have done the surgery, and we're talking how much in lost time from work? You're talking maybe 6 weeks.
Well, it's not only lost time in work; it's the ability to fix something that you could have fixed. I mean, certain injuries have an acuity. A flexor tendon should be fixed within 2 weeks. Any flexor tendon that's not repaired within 2 weeks is bound to not do very well. A nerve injury, a mixed motor nerve, should be fixed quickly. And a lot of times it's missed. So, I mean, you only have a short window. I would venture to say probably 3 to 6 months to fix those nerves. And once they see me, sometimes 3 to 6 months later, when they're getting their second opinions or takeover cares, I don't have a lot to offer them because the window for repair. So yeah, there's time off work ultimately, which frustrates everybody. But there's also the patient is unfortunately, permanently hindered because of the inability to spot the injury. And that's fair. I mean, there's just certain things that when you see hand surgery all the time, you look for, just like as a spine surgeon would look for spine things that I probably would miss too. So to be fair, like it just has to do with our specialties. We're so subspecialized, we know what to look for. So
in with our work comp program at Optum, you usually get them in within 24 to 48 hours. So you're really good about getting those patients in. So I'm very appreciative of that. And our employers really like that they can get them in quickly. So this should not happen with your patients, that's for sure.
No, and you call me all the time, you text me, and again, it's our privilege. Now, sometimes, for the sake of schedule, they have to see the PA, which, is just, remember the PA is a direct extension to me. So as long as they're okay, we've got a PA in clinic every hour of every day, Monday through Friday. So, but at least getting the ball rolling. If I could be in 2 places at one time, I would. But I think we have a good team, and I think you're really good at getting those patients over to us to be seen acutely.
Thank you. What are the most exciting advancements in hand surgery right now? I know that you're on the cutting edge of the new technology and so forth. I'd love to hear more about that.
Oh, man. I'm actually giving a few talks on this. One down in Naples, and I'm doing another seminar this summer. So I guess you can segue it into so nerve surgery used to be the great abyss. I remember in my training, 15 years ago, we were told that nerves never do well, don't bother fix them. And then when we did replants, we would do all of the bone fixation, tendon fixation, revasc, and then we would leave the nerves at the end for the intern to sew up. And I would argue that the most important part of a replant is the nerve repair, because again, what's the point of having a finger if you can't feel it? So, or use it. So the nerve repair is the most important part of that whole process. Now, we were told a long time ago that nerves don't recover. They have terrible outcomes. That's just not true. Nerve reconstruction with some of these nerve allografts, autografts, and the technology that we have to repair and reconstruct nerve has pushed us light years into the future. So nerve surgery, if done in the right hands, can be extremely effective, almost to the point where you're restoring normalcy. And we've just never seen those outcomes 20 years ago. So that has truly been impressive. The biologics, the orthobiologics has been huge. I rarely treat tennis elbow anymore with surgery. PRP has been so effective. One of the reasons why PRP has been discredited is because some of those spins, we weren't getting enough platelets. You were getting, barely 1 billion platelets. Now these new spins, the Arthrex system, the Bioventus system, even the Progen system can get platelets north of 5 billion platelets for an injection, and some cases 10 billion. So you're talking about a concentration where you're getting 10 times more platelets than you did even 10 years ago. So the technology's gotten better. Our ability to heal tendons without surgery has gotten better. And that's a testament to workers' comp. For you guys are the only insurance that approves that. I will encourage you to keep doing it, because I can promise you a PRP, it's not cheap, but it's cheaper than surgery. It does work reliably. There's evidence all over the place for that. I've done thousands of PRP injections. I've done them on myself. I believe in them. There are certain things that can be healed with PRP, and I would encourage all workers' comp to consider that. Insurance companies don't it's all cash pay for other insurance companies, but workers' comp is ahead of the curve, I think, for allowing that. And I think you guys will notice that from a cost perspective, it's way cheaper than surgery, and the time to recovery has got to be quicker. I would imagine you're shaving off probably 6 weeks, just because you're not making an incision, you don't have swelling, less therapy, and you're letting the body heal itself, which is what it wants to do. So you're giving it, high-powered platelets with the associated enzymes to put in the tendon and heal the tendon. So I think those are huge things. Hardware is getting better and better, smaller, more contoured. The screws are getting better. We have one of the things in hand surgery, we're doing minimally invasive percutaneous fixations with headless screws, intramedullary screws. We don't even make incisions anymore. We're fixing fractures without making incision. So that's less swelling, quicker recovery. There's too much to go on. I'll be here hours, but yeah, the hardware's gotten better. The science has gotten better for regenerative, and then certainly nerve surgery is light years above. Now, if anyone tells you nerve surgery doesn't work, I've got about 100 different videos and case studies to show you guys.
So I think I may need a PRP injection myself because I've got a little bit of a tennis elbow. I think my issue is from being a side sleeper and keep tucking that arm under the pillow at night. Yeah. I'm wondering if that's part of the issue. Do you see that for side sleepers that have a tendency to tuck that arm up under the pillow?
Do you hurt well, it depends. So like if you hurt on the inside of the elbow right in here, it's probably cubital tunnel, which is typically positional.
No, but it's on top.
It's on top, yeah. Tennis elbow happens to healthy people doing healthy things. Unfortunately, it's not. We call it tennis elbow, but I would tell you 99% of people I see with it never played tennis. So it is really what it is. It's unfortunately the tendon wearing out. We are organic beings. We're made of carbon. Anything that's organic, or even inorganic, anything in the world will eventually wear out. Just like the tread on your tires that's getting thinner, a rug in the corner of an old house, it'll peel off the corner. Anything that has traction on it will wear and tear. The tendon, unfortunately, falls apart. It's not an inflammatory thing. If you took a microscope to the tissue on your tennis elbow, you would not find inflammatory cells. You would find angiofibrotic dysplasia, which is basically this tendon that's wearing out. And it's part of, we call it a disorder of middle age, unfortunately. No one likes to hear that. I've had it. But we treat it by either completely cutting it out and taking good surrounding tendon and tying that to an anchor, which is the surgical part. You could also release it. I'm in the camp of fixing it and debriding it. But then again, injecting PRP, you're now adding fresh cells with associated enzymes to go in and sort of regenerate the tendon. And I like that because you're doing it, again, non-surgically, and you're unlocking the body's ability to heal itself.
Well, I will definitely schedule an appointment because I think I may need. I've been kind of in denial for some time over that. Well, we really appreciate you spending this time with us, and I've enjoyed this so much. I don't get to talk to you that much. We're both so busy. Let me know if you have any questions on the work comp side. We're glad to answer those. And I just wanted to say thank you.
Oh, it's my pleasure. Workers' comp is. It is rewarding. It is challenging. You guys, you see, you have to be dedicated to it. It's a lot of paperwork. It's a lot of getting to know lawyers on both sides. But ultimately, if you do it fairly and you have an algorithm, I think ultimately it works out for the best for the employer and the employee. But yeah, I think it's really important. I really like having guidelines. I think my advice would be, as you guys, I know you guys are really involved in that, continue to provide us guidelines because sometimes we need support. And patients will become unruly. They'll want to be treated differently. And, if the employers are paying a lot of money for you to get care and they want you to get better, but, people are people and they'll want to do what they think is best for them, whether or not it's right for the company or people can be selfish. But I think providing guidelines and giving us like the standard of care and saying, look, after a carpal tunnel, 6 weeks, it's the standard of care. We're at MMI. I know you want to treat people uniquely, but having a set of guidelines allows us to counsel patients on what the expectation is. Because, some people will come in and expect, that's important. They'll expect 6 months off for a carpal tunnel, and that's just unreasonable. That's not reasonable. But setting a standard of guidelines that we can agree on in this state and providing that to people like us really helps us help you. Because a lot of times, and I tell lawyers this, we're on an island. You guys, we see them, we have to talk to them, and when we send them back to work, they're not always happy for whatever reason. Or sometimes they want to go back to work. And the opposite is true. They want to go back to work, but you can't because they got an open wound. So the truth is we're sitting there talking to them and their families in these traumatic times, and we just need guidance. And I think it's helpful in the beginning. We can say, look, here's your condition. We're going to treat it. And the expectation is that, at 6 weeks, we're going to send you back to light duty. 3 months, you're at MMI. And creating an algorithm will help us. It'll help get unity where you don't have people abusing the system. Because if there's an expectation that this is how it is in Georgia, I tell people all the time, I go, this is the expectation. This is how it is. If they're going to pay for your care, this is where we want you to be. And that really, really helps. It helps avoid any sort of struggle. So as you guys go to these meetings, as you guys create policy, believe it or not, we want rules. We want expectations. We want timelines. That'll really only help us.
I'll make sure to deliver that message to our industry professionals, and we truly appreciate your time. I know you're very busy, and we really appreciate this extra time we had with you this afternoon. Thank you so much.
Thank you, Donna. Thank you very much.
Thanks for tuning in to Workplace Health. I appreciate you spending your time with me today. Don't forget to follow us on social media, subscribe, leave a review, and share with an industry professional. Stay curious, stay kind, and we will see you next time.